Hello and welcome to On Call with the Prairie Doc After Hours. We had many great questions submitted beyond what we could answer during the broadcast portion of our show, so let's get started. My 15-year-old daughter has Marfan syndrome. Wow, that's interesting. I've never had a Marfan syndrome patient. I thought about it. And she has an aortic root aneurysm that's 4 centimeters. Will she need surgery down the road? What is the prognosis? Bruce?
That's a great question. It's dilated, and the chances are for further root dilatation and progression are significant. And again, as Mike said, dependent on body habitus and all, but needs to be watched very closely. 4.5, is that the 4.5 or 4.4?
It's smaller than an average person because the tissues aren't genetically normal.
Mm-hmm.
And the thing is the thing that got me is that she's 15, and so 4 is pretty big for a lot of 15 years olds. So it really takes somebody that's an expert in that area. The other thing is she's coming into what they call the fertile female ages, and so the hormones a lot of times will have some effect on the degree of enlargement, and particularly if she got pregnant.
Huge demand on the heart.
Well, on the aneurysm and the force, the shear stresses that are on there for delivery. Now, I do have 3 or 4 Marfan's patients, and one is just an absolute delight. She comes and sees me every year. She's delivered 2 kids and has not had to have her aorta replaced yet, but we have her blood pressure under tremendous control, and it's something that it's never too early to go and get some. She should have somebody already, an expert in that area following her.
Very important.
Right.
Yeah, Marfan syndrome, usually the hyperelastic elasticity can bend their elbows backwards, and they're tall and thin, and their connective tissue is weakened for some reason.
Fibrillant.
Huron viewer says, doctors recommend that I get a Watchman heart procedure, and I was wanting to know more about it and hear what the doctors think about this new procedure, Watchman heart procedure. Have you heard of that, Bruce?
Thinking about the Watchman device, and that's utilized in patients with atrial fibrillation. The main nidus, or place where the clot forms in our upper chamber of the atrium, is in a little dog ear outpouching called the atrial appendage. And we do have a device that if there's an absolute contraindication to being on blood thinners or high risk for blood thinners and high risk patient for stroke, including a lot of things, advanced age and hypertension, diabetes, heart failure, those things, that those patients can be effectively treated with this device that is placed just within that appendage, seals off the appendage, and then gets a nice smooth coating, and the stroke risk by some of the earlier trials is comparable to being on a blood thinner.
Okay.
So it lowers it to that type of risk.
We do that procedure at the heart hospital, and it's only in carefully selected people to make sure, as Bruce said, that it's appropriate.
Right.
But if they have any question whether they would be a candidate, they can ask their doctor, and maybe they can tell them. But if they want to have us have a look, we're happy to do another opinion. We're happy to do that.
You can get a second opinion and go right back to the original doctor.
Absolutely.
I do that. I've done that, and so that's not a bad idea.
Yeah.
My doctor suspects that I have costochondritis. Should I have an EKG done to confirm the diagnosis?
Costochondritis is an inflammation of these bones along your rib cage right up against the sternum, and that you do not make that diagnosis with an electrocardiogram. Okay, they might do an electrocardiogram to make sure that your heart's okay and they're not getting confused or covering up, but it's inflammation of the bones. It's and the cartilage along your breastplate, and sometimes it gets misconstrued as being related to your.
So it's not heart disease; it's chest wall pain.
Chest wall pain, exactly.
But sometimes it's very much like.
But it can camouflage what might be a heart disease underneath the surface.
So it's a good idea to make sure it's not heart, because sometimes it's heart, not.
Especially if this particular questioner is saying, I've read through everything, I think I have costochondritis.
Yeah.
It would be good to get it confirmed. That is truly costochondritis.
Go make sure that it's not your heart, because you're not going to die from costochondritis, but you might die if it was heart disease.
You could.
Right.
Yeah.
Sioux Falls woman says, I've been told I have a lipid infiltration of the septum. Does anything need to be done about this? Would weight loss help? Lipid infiltration of the septum.
Yeah, I don't know the answer to the last part about whether weight loss would help, but many thin people can have what's called lipomatous infiltration of the septum. The septum is the division between the two upper chambers of the heart, the right atrium and the left atrium, and you can have a lipomatous hypertrophy of the interatrial septum, is how it's often termed on an echo.
And do you do anything about it?
No.
You don't do anything about it. We had a question on Facebook. Pulmonary fibrosis. What is pulmonary fibrosis, and could you tell me more about it?
Pulmonary fibrosis is an inflammatory disorder that's usually idiopathic that affects
Idiopathic?
Idiopathic is this fancy $65 mumbo-jumbo doctor word for they don't know why you get it.
Yeah.
Okay. So the deal is though your lungs have some delicate, almost like lace tissue that holds the lung together. So it's kind of like if you think of your lung like a sponge with all the little pockets, and the fibrous part is the sponge part. And so in some people that's fine and delicate like lace, but sometimes it gets very thick and stiff. And it makes it difficult for the air to go from the air passageway into the blood. And it really can cause a lot of trouble for people. It's usually a slowly progressive disease, and it's usually managed by lung doctors. We get involved because when the lungs start to get problems, then the heart, of course, acts up and gets problems.
That's right. The heart is a sympathetic organ.
Right.
It senses the illness.
Stress, any kind of stress on the body. That's what we were talking about before. The person was asking about the prednisone.
What is the present status nationally and internationally of the surgical procedure where they reduce the size of the ventricle to treat congestive heart failure?
It's in this hemisphere we don't see it much, but there are some definite indications why it would be considered. The left ventricle, when it forms an aneurysm, is the usual reason behind it, and the aneurysm is when you've had a heart attack, the left part of the heart dead, and it's not working, and a significant amount of the cardiac output is just pushing that aneurysm out and not doing any effective forward blood flow. But
so there's, in some cases, they were actually cutting that aneurysmal part out.
They would remove that.
Sewing the heart together.
Just take that out, sew it together, and it's a highly technical, not for just anybody to do. You want a surgeon who's very skilled at it, knowing exactly how much you can remove. Other indications are if you have intractable arrhythmias or ventricular arrhythmias and recurrent congestive heart failure, as we mentioned.
How about IHSS? Explain what that is. Actually, why don't I throw it this way?
Yeah. So well, just one more comment about the aneurysm. We almost never see that surgery anymore because there's so many things we do now right away if we know somebody has a heart problem, is that almost we don't see aneurysms anymore. In our early days when we were first starting, when I didn't have all this gray hair, that you would see those aneurysms, and you don't see them now because we intervene on everybody before they get that. The hypertrophic part that you're talking about is inappropriate growth of the muscle, where the muscle gets very thick, usually in a focal area of the heart, but it can be the whole heart, but it's usually in a focal area, and it's usually associated with things like sudden death, arrhythmias, shortness of breath, difficulty with the blood getting out of the heart, and there's a variety of ways to deal with that illness. The genetics for that is becoming more and more developed all the time, but even if you don't have the genes for that, only about 30% or so of the people have the genes worked out for that, so it's possible to have that disease even if your genetic testing is negative.
Right. And some of those people go to resection of that segment of the septum usually that's thickened, and they'll resect that. But I've seen people die from the surgery. I mean, it's a first of all, do no harm kind of a tough
It is,
question.
and it's like everything that we do, you have to know all of the details. That person that talked about bringing their records and their information to the appointment, it's crucial that we know everything about it to give you the best outcome.
There was a question about Carvedilol or Coreg. Does it ever cause the same problems like lisinopril, or what are the side effects of Carvedilol?
Carvedilol is utilized. It was really in 1991, 92, I think the original article came out, and it reduced mortality from heart failure, predominantly systolic, the pump muscle not working well, tremendously. It's a huge,
wonderful
huge
improvement.
Yeah. And that drug is has a lot of different effects, but it does have some beta blocker effects, and beta blockers are the medicines like metoprolol or low pressor, but it can have a heart rate slowing effect. But the biggest thing that happens with it, when we first used to start the drug, we'd have to bring them into the office. A patient would take a 3.125 milligram tablet. We'd monitor the blood pressure for 2 hours, because fairly profound blood pressure lowering. But side effects, as you mentioned, if you overtreat hypertension, you may be quite lightheaded. A lot of these patients have very severe heart dysfunction. We're trying to get them almost to that point where they're just a little lightheaded, so the heart is not working against any resistance, so it can heal and not form an aneurysm, which we would have to cut out later, and that kind of thing. So by and large, it's a relatively well-tolerated drug. It's twice-a-day dosing. It's important to take it relatively 12 hours apart.
That drug is used commonly with lisinopril.
Yes.
Those two drugs are almost always used together because they work by different mechanisms. And so it's completely different than lisinopril, and it works by a different mechanism, so you very commonly see both of those drugs together, not one or the other.
I think in my era, the reality of the the potassium-sparing diuretics, the Carvedilol or the lisinopril, and then the Carvedilol on top of that, huge improvement in heart failure.
Right.
Wonderful ability to bring people out of their lungs filled with fluid and miserable, give them quality of life with that. Propafenone or Propafenone. Is Propafenone used exclusively to treat atrial fib?
Yes.
Okay.
Once in a while they might use it for ventricular arrhythmias, but I'd say 90% of the time, 95%, is all used for atrial fib.
Okay. What is the difference between atrial flutter and atrial fib? Is a flutter a more serious or a less serious problem?
Great question. Atrial flutter, instead of that fibrillary motion that we were talking about earlier, where it's firing at 1,000 beats a minute, the atrium are rhythmic, but still firing too fast at 340 and not really, giving out an effective output. In the past, we kind of thought, well, maybe it's not so bad since there's still some organized activity, but we do know from a standpoint of stroke and stroke prevention, which is the most worrisome thing that we encounter with the AFib and aflutter, that we treat them the same.
Yeah, the same prognosis, same everything. Yeah.
They're a rhythm that's on a continuum. They're different from the doctor standpoint, but from the patient standpoint, they're very similar. The only difference is that both of those rhythms can be ablated, but it's a little bit easier to ablate atrial flutter than it is to do fibrillation.
Oh, didn't know that. A man from Watertown asks, a relative was in for radiograph of the spine after falling on the ice. Radiograph showed calcification of the aorta. What's the significance of this? He's 60. Calcified aorta. Now, I mean, we could talk all night long about calcium scoring and all that. I really don't want to go into that. I'm not a fan of it, but at the same time, calcification isn't that unusual, particularly in smokers, is it?
Right, very common. It's a marker for the process of atherosclerosis, and our atherosclerosis is a remodeling and a healing, and just like the orthopedic surgeon throws up a knee X-ray and says, "Look, you've got all this inflammation. Look at the calcium buildup in your joint." The body is laying down calcium, smooth muscle cells, trying to stabilize that aorta from further damage, but it's an ongoing process, and it would be one that somebody would want to look at that X-ray and say, well, it looks like it's the same caliber. There's some people that have calcified aneurysm. It's a big, but he would be somebody who very much you'd want to have an aortic aneurysm screen, peripheral vascular screen, assess his risks and treat effectively.
Right. A woman asks, if my husband has a pacemaker since '96 and never had to use it, can it be taken out? Mike?
The pacemaker can be taken out. Sometimes, in fact, the very first person that had a pacemaker had it, and their rhythm recovered, and they were able to take it out. But he had to push that pacemaker in a shopping cart in front of him at the store. So it was very much a convenience deal in that situation. But the deal is nowadays the selection of people that really need pacemakers is so stringent that it's very uncommon to have somebody that you would run into like this and then take it out later. This would be something that was maybe put in years ago, and maybe they didn't understand the guidelines as well. And now things have gotten so specialized that most of the time cardiologists are the ones putting in the pacemakers, are a little bit more familiar with what the guidelines are.
Yep.
So it'd be very uncommon to have somebody in this kind of scenario.
Now, and if you take out the pacemaker, you will generally leave the
wires, right.
because you can't get that darn wire out. So
You can, but there's a significant
risk.
risk in morbidity and mortality. What I mean, morbidity, chances of causing harm, and then even death from trying to get those wires out.
Right. I had a heart attack 14 years ago, 5 stents, and discovered a good book called Before the Heart Attacks by Superco. I keep hearing there have been advancements since then. What books do you recommend for 2019 that deal with secondary prevention of heart? I would just say this. I have a book called Aging with Grace that talks about prevention of aging. And I would recommend the book. It's my own book. How's that for being self-promotion? And but do you have other books that you would recommend?
You know, there's from a prevention standpoint, just a general book about Mediterranean diet, just a different diet plan. Is that, you know, people are always asking, well, how can I lose weight? How can I diet? What should I do?
Yeah.
And it's just kind of eating the right types of foods and paying attention to what we do eat. You know, self-help books, meditation, yoga, stress reducers, and weight loss. Big key.
The thing I would recommend is, in the world there are these areas called blue zones where people live to be 100. And when you talk to the average person on the street, they say, I don't want to live to be 100. Who wants to do that? But this is not people that are looking out the window from the nursing home. They're dancing with their wives. They're taking their grandkids fishing. They're very functional 100 years old people. And if you look that up, or look up longevity on the internet, the oldest person in the world that most people don't know, and I ask this question to patients all the time, was 122 and 164 days. And so you think about what it was like when that person was 100. They must have been like marathon running or doing something that was amazing. And so, but we don't think about this stuff when we're 20, which is when we should be thinking about it. We don't think about it till we're 65, and you start to look in the mirror and think, oh my God, where did the glory years go?
Yeah, gee. And I think the main thing, and the blue zone story, well, Life's Final Season, if you get that book, it talks about the blue zones. It talks about, you know, a regular exercise program. It talks about eating less and a Mediterranean diet and all those blue zone diet things, and being connected to somebody that you care about and interacting with people regularly. And finally, the idea of connecting with a higher being. You know, that
the deal is your spirituality and then the relationships. And it turns out that your sex life is important, and that doesn't mean just the intercourse. It means having a person that's your, you know, companion or life partner and all of that stuff to help you wade through the stressors of life and pull you through in your low dips and so forth. And it turns out that's enormously important for you to be able to, you know, make it into this longevity.
Yep, no question. Cardiologist talking about love and faith. How about that? I love it. If your blood pressure, systolic and diastolic readings are more than 100 points away, should you be concerned? What does a wide pulse pressure mean?
Right. Wide pulse pressure is characteristic, when we think about it, as a sign oftentimes that maybe the aortic valve is being surged open but leaks backwards. So there's a discrepancy between hearing that surge in the blood pressure and then when it goes down. That comes up a lot of times. Sometimes if the individual's asking, well, my blood pressure was 140/30, and elderly patients, and oftentimes they'll have the blood pressure they're listing by auscultation. Calcified vessels or rigid vessels can oftentimes make the sound transmit down to almost
30.
zero, and you're okay, but
It sounds
it's
like it.
relative. You know, if you're talking of a split of 220/120,
Then there's a
real
problem.
significant, right?
No. So that pulse pressure is an issue. And you get it when you're older. I mean, stiffer blood vessels. And the problem with that is if you have 180 over 80 and you lower their blood pressure with a blood pressure medication carefully, sometimes they won't tell you the fact that whenever they stand up, they just about pass out. They have to stand by the bed for quite a while. And the risk of falling and slamming your head into the floor or down the steps is greater than the risk of...
The one thing that I would say about blood pressure is it's something that 92 million people have, but it's managed quite casually. You get started with a medication that you're going to take for 60 years in some cases, and you just sort of get the pill of the day, you might say. And most people don't check their blood pressure at home, and they get it only once or twice a year in the doctor's office, and most people aren't going there to get plane tickets to Florida, so their blood pressure is elevated. You get the white coat syndrome, right? Because they're worried about the bill, or am I going to be late, or what's he going to say? And so at home in your living room, so it's very common for us to give a person a diary and say, measure your blood pressure at home in your living room, because that's where you live. They're nervous when they come to the doctor, the blood pressure is 180, I give you some pills, and then next Wednesday you call me and say, I'm dizzy from those pills you gave me, because now their blood pressure is, 90 or 100.
Yeah.
And so at home in your living room is where you live, and that's where you should check your blood pressure, and then you can get much more appropriate management.
Those are really good words of advice. I'm 55, I have a resting pulse of about 50 and a blood pressure of 130 over 75. Are these normal values?
They're great, especially if you're a runner and fit.
Yeah.
Too. I mean, 55 is certainly nothing to be
Right.
at this age.
I'm not happy about the new numbers that they've come out requiring that we get those blood pressures lower and lower and lower. I think that there's times when you protect the heart and you need to do that, and I think you let it run high for a long time, people lose their mental capacity. I mean, even without observable stroke. I'm in favor of controlling blood pressure. But there are a lot of people whose blood pressures, particularly in the elderly, get too low. And I worry about it.
I think you're right. I've been listening to a fair number of audio tapes and doing some reading. And I do think we've kind of got a little too far. I was kind of doing that too. I thought, gosh, we've got a lot of people, ladies, complaining they're constantly dizzy. But it's also a function of our autonomic nervous system in terms of auto-regulation of our blood vessels, and that's part of the problem why we're standing up. Yet throughout the day, if they're sedentary, their blood pressure is high, and it is working out the heart. So we have to find some way to balance, whether it's going to have to wear some support stockings, try to do things that assist us in getting the regulation.
Yeah, you mean to tell me that we need to individualize our care with every patient?
We need them to see Dr. Holm and get this figured out.
How great is that? Last question. A viewer from Platt says, my mother had 3 aneurysms. How important is it that her children be checked for aneurysms? Now, I don't know where they're aneurysms.
This goes to that screening question that you were talking about before, Rick, is that the offspring should be checked. And the thing is the age at which they should be checked is also important. So the age at which that person's, developed their aneurysms. Because if you look too soon, you may not find what might be there later in life. So you want to make sure that they're into adulthood. And then, of course, if that's your family genes, you don't want to be running around with high blood pressure. You don't want to take up smoking because you don't want to poke the bear, I guess, that people say.
That's a good one. We did have one other question. Someone called in and asked, what is the subclavian steal syndrome?
Wait, they're tough questions.
They've been doing some reading.
A lot of times, best way it's usually diagnosed is if somebody comes in, they're symptomatic, they're having weakness in the arm, and they're using it, a symptomatic subclavian steal syndrome in terms of shunting blood in a different direction up through our arteries in our head, coming around and coming in reverse to get around a blockage that's in your arm arising from the aorta through the subclavian artery, say to the left arm. And they'll have a discrepancy in the blood pressures And oftentimes more than 60 millimeters, 40 to 60 millimeters difference between
The right
one arm
and the left.
But then it's compensated for by these vessels that grow around, and you know, if somebody's coming in and they get dizzy and woozy every time they're using their left hand.
Because it's sucking the blood from the
brain. Or it's very important for us if somebody's going for open heart surgery and we fail to check blood pressures in both arms, and they put a bypass in the internal mammary artery and it's blocked between the two. Every time you use the left arm, you start getting angina. So stealing blood away.
I hadn't thought of that.
Yeah.
Well, great answering. We really do appreciate you staying late and giving me and all your guests out here these wonderful answers. Thank you both.
Thanks, Ray.
Thank you for joining us on our Facebook page. We appreciate all your questions and the opportunity to answer them. And until next time, from all of us at On Call with the Prairie Doc, stay healthy out there, people, and happy Valentine's Day.